Good afternoon, ladies and gentlemen. My name is Stephan Windecker. I'm from Bern, Switzerland, and it's my distinct pleasure to welcome you on behalf of my co-chair, Vijay Kunadian from the United Kingdom, to a symposium where we address the care of female and lower risk younger patients. Of note, this symposium has been made possible by Medtronic. It is sponsored by Medtronic. Now, I just want to leave you with some introductory remarks. And first, if you look at some European data from the ESC EORP valvular heart disease survey, then you do note on the left side that actually in terms of prevalence, aortic stenosis is the most frequent lesion leading to an intervention, and that the frequency distribution in terms of sex, male and female, is rather similar. Conversely, if you look at the management of aortic stenosis, there you see that the actual rate is similar between male and female patients, but there are some nuances as it relates to the intervention age, to the choice of prosthesis, mechanical versus bioprosthesis, and a surgical versus transcatheter approach. Now, it's also interesting to look at the frequency distribution of sex across the major randomized clinical trials and large-scale national registries. And here at variants, for example, with coronary artery disease, you do appreciate that actually the representation of female patients is nearly at 50%. But importantly, there are sex-related differences. I already mentioned the diagnosis is usually occurring at a later age. There remain concerns of undertreatment of severe symptomatic aortic stenosis. There are clearly important differences as it relates to pathophysiology, left ventricular remodeling, prior and after aortic valve replacement, and there are relevant differences as it relates to the anatomy, where it is more fibrotic as in female patients as compared to male patients. And finally, there are issues related to hemodynamic characteristics due to the smaller size of the annuli. Now, another topic we are going to address is lifetime management, and this is important particularly with the expansion of the therapy to younger, lower risk patients. And here we need to discuss issues related to durability, importantly the risk of reintervention, be it redo TAVR or an explant TAVR, and the issue related to coronary access, the risk of coronary obstruction, and long-term management to avoid patient-prosthesis mismatch. Now, we are fortunate to already have data, robust data out to 5 years and preliminary data out to 10 years that likely there are no relevant differences between transcatheter prosthesis and surgical prosthesis. But I just would highlight that there remain subtle nuances. We started in an era defined by surgical definitions which were crude, limited to the need of reoperation. Then in the 2017, we introduced the absolute echo-derived measurements, and more recently, we moved to the heart valve collaboratory consensus, where we take morphological changes and echocardiographic changes and clinical sequelae in an integrated approach. I'm closing with this slide indicating that we are privileged to have a plethora of evidence, both in terms of comparison TAVI versus surgery, but also recent strategy trials. So this is really a field rich in evidence, and we certainly can capitalize this during our discussion, but also in the future to define future studies. And with this being said, I also would like to welcome our international faculty who will engage into the presentations and the discussion. And it's my pleasure to introduce the first speaker, who will be Birgid Gonska, Julia Grapsa, who will be discussing advancing the care of female patients with aortic stenosis. Julia?
Thank you so much. It's a great pleasure to be here. So let's talk about women and how actually we can improve the care of female patients with aortic stenosis. So as we know, and Professor Windecker demonstrated, we know now we have a lot of evidence that women are underrepresented because up to quite recently, almost 70% of men were included in low-risk randomized controlled trials. We have, of course, SMART and RIA, that they included a great percentage of female patients. And practically, we, even on the latest guidelines that they were published yesterday, we saw very minimal changes with regards to sex differences. They actually decided to use the body surface area to index. But we know also that women are more likely to suffer from paradoxical low-flow low-gradient aortic stenosis, which is also underdiagnosed because people, they cannot measure it sufficiently. And of course, it usually delays to get a proper workup and procedural waiting time is longer in women. There is a confounding, a series of factors that contribute to that, as we will see later. But they come to the doctor quite symptomatic, and usually the deterioration is more rapid. So a common clinical scenario is an 82-year-old lady. She will come to your clinic, and she has a background of hypertension and diabetes, and she has been complaining of shortness of breath for the last 12 months, and she's not as she used to be. So the general practitioner actually diagnosed with her with iron deficiency anemia, and he considered that practically that's the cause of her shortness of breath, and prescribed iron tablets and vitamins. And because of the age, he said that take it easy. You know, you are 82, you need to take it easy, and that's why you're breathless. But one day, the patient started having chest pain and visits emergency department, and practically she has on the EKG LVA changes, troponin was negative, and then a murmur was heard. And then they discharged her because troponin was negative, and an echo was booked in 3 months' time. But the patient actually, after a few weeks, she has a presyncopal episode, she gets admitted, and she's diagnosed with critical aortic stenosis, and then her ejection fraction was only 20%. So what went wrong? So first of all, there are significant differences in clinical presentation, and we have actually a lot of papers documenting the differences between men and women in aortic stenosis. Women will present with shortness of breath, dizziness, and syncope, while actually men are more likely to present with angina, like chest pain. And men will present younger, while actually women will present at an older age, with more advanced heart failure symptoms, and more frequently they have diabetes, hypertension, chronic lung disease, and AF, while actually men will have more likely coronary or peripheral arterial disease, simply because the percentage of smoking is actually higher in men rather than women. But important is actually the communication. We cannot pose the same questions between men and women. Practically, you know, women are multitasking, they have their families, and if practically many times that I have tried to admit a female patient into the hospital for workup, they say, I need to look after my husband, I need to look after my kids. So practically they have a million thoughts that they are going actually, they are thinking. And so they usually perceive the symptoms as less severe. They may have shortness of breath and they may ignore it. They may feel dizzy and they may practically ignore these symptoms. I had another patient that she was telling me for weeks that she was asymptomatic and she had severe aortic stenosis. And then when we did her TAVI, she said, I feel better now. I don't have dizziness anymore. I said, you never told me you had dizziness. You know, that's something very important that we need to know. But think about asking, like comparing to previous workup that they were doing. How is, do you manage to do the same household works every day? How many meters do you walk? Do you feel more breathless when you carry weights when you go to the supermarket? You know what we decided? We felt that the aortic stenosis women is very important, and with Professor Prendergast, who has been my mentor, we designed this only 12 pages document that practically, and it has been the most visited page within the website, that we have a questionnaire about symptoms. And practically a patient can go through this questionnaire and they can actually tick what they have, and they can go to their doctors and say, here is what the symptoms that I have, what is next? Because aortic stenosis is actually quite important in women. As you will see, there is there is significant percentages in men and women for patients suffering with severe aortic stenosis. And practically, even if we take randomly elderly individuals, you will see that it's a percentage that is equal between men and women. But again, in going deeply into the pathophysiology of aortic stenosis, in women we have less calcification and we have fibrocalcific aortic stenosis, while in men we have more significant calcification and we have eccentric hypertrophy, while actually in women we have concentric hypertrophy. That's why we have paradoxical low flow low gradient. And as I said, again, many times I see that is not well quantified, the paradoxical low flow low gradient aortic stenosis. Another important part is that we know that if aortic stenosis is diagnosed early and it's treated early, then survival is more optimal. That's why echo is a key examination in the first line imaging modality to diagnose aortic stenosis. And this is actually included in patients. So what are the steps of diagnosis? Is clinical examination, of course. Never forget your stethoscope, vital signs, EKG, and then, of course, an echo, including stress echo, or, of course, if needed, then CT. And then the patient is being discussed in a heart MDT. But still, you will be surprised that if we compare men and women, women have a lower rate of obtaining an echo, even if they have symptoms, because it's both sides. Either their symptoms are underestimated, or, of course, they have some reasons to delay their echo time. But when we find that someone has a low flow low gradient aortic stenosis, this contributes to worse outcome. Again, I will reiterate that there are sex-specific differences in imaging, both in echo and CT, that they will need to be included in the guidelines. And here are two different examples. This is our patient who presents with severe low flow low gradient aortic stenosis and with very minimal calcification, but someone with a male patient with severe calcification and also with severe low flow low gradient aortic stenosis. So now when we treat women, we know that they do better with TAVI rather than with a surgical AVR. And this is what prompted people to start including more women and, of course, to have the two major RCTs, as we will show you. And this is a very important table on the paper that we published in Structural Heart with Julia Macero and Professor Kiefo and Vijay and many other authors, that practically you see the significant differences in men and women about the aortic stenosis. So we need to take into consideration that women have small aortic root, low coronary ostia. That changes actually the procedural, the way that the procedure is being done, for example, the TAVI. And for example, the selection of patients will be different depending on the anatomy and physiology. But also there are very significant specific factors such as the patient prosthesis mismatch, the pacemaker implantation, the valvular and bleeding complications or acute coronary obstruction that they need to take into consideration. Reaching to an end, practically the women with severe prosthesis mismatch are at higher risk for death, stroke, or hospitalization, and this happens when they have smaller annuli, which is very common in women because of the lower body surface area. And practically the SMART trial was the first major randomized controlled trial to recruit mainly women. And it showed practically that the balloon expandable valve is actually non-inferior to the self-expandable valve. So it's very important to think that when we select the patients for TAVI, what to ask them and what to suggest to the patient. They had differences in pacemaker implantation or patient prosthesis mismatch. So it's very important to address this, and we have already the 1-year follow-up. Then the RIA trial also showed that at 1 year, in patients with women with aortic stenosis, the incidence of composite of death, stroke, and rehospitalization was lower with TAVI than with surgery, which confirmed actually the SMART trial. And reaching to the take-home messages, I will say communication is number one. Change the way that you ask your female patients about their symptoms. You know, ask about their household, ask if they can manage their kids and their husbands the same way and their families the same way as they used to do. So remember that there is equal percentage of women and men in aortic stenosis. Remember that delay in referral and treatment actually has worse outcomes and impacts survival in women. But be aware of sex difference in aortic stenosis. I hope that we will see a lot of these changes being implemented in the next guidelines, and also that women have higher surgical risk and smaller annuli, and thus they may qualify, they do better with TAVI rather than with surgical AVR. And this is what we say, that the work on sex differences is actually of pivotal importance. With that, I would like to thank you for your attention.
Okay, thank you very much. I think my mic is on. Now it is on. Thank you, Julia, for that. Excellent. Just stay there because we're going to discuss your presentation. So may I just encourage if the audience, if you do have any questions, there are 2 microphones in the front and there are also some at the back as well, so please do come along. So while you're thinking about the questions, I just want to highlight the significance of diagnosing women correctly. This is something we've been saying for years. Women are underdiagnosed, not just only in the valve space, but also in the coronary artery space. But from your presentation, there are maybe 2 areas before these patients come to the hospital, like the example that you mentioned, and also after they come into hospital, there are potentials for underdiagnosis or misdiagnosis in these patients. And of course, when you speak to clinicians, they say, no, I treat women and men equally. But then you showed nicely there are so many patient organizations. And if you listen to the stories of patients whose diagnoses have been missed, and of course they get admitted to hospital, the immediate reflection is to do troponin. And if the troponin is negative, they get discharged while nobody is thinking about could it be something else. So, so from your perspective, how are we to address those initial, and of course if they come to us with all of the diagnoses and we have the strategies available?
You know, that's a very good question. I'm an echocardiographer, I'm an imager in valvular heart disease, so I'm running everywhere with a portable machine of echo, and I scan everybody, like everybody that I will see. I do a probe, it takes 5 minutes in order to do a quick look of the valves. So if a patient comes to you with reasonable symptoms, do not actually underestimate their symptoms. It's better to do an echo rather than not doing it. So I have a low threshold to stethoscope, EKG, echo, and of course troponin, or a BNP if needed. But I think to lower our threshold to listen to our patients and practically get the appropriate tests soon rather than late.
Yeah, absolutely. After a certain age to think about, because aortic stenosis is one of the commonest conditions other than coronary disease and atrial fibrillation, for example. So people should really think, I mean, could this patient, and literally it doesn't take very long to take your stethoscope and have a listen to the murmur. And then once you have a murmur, you send them to the hospital to have an echocardiogram. But that's, you showed in your data that women are less likely to get even the basic echoes. And even after they present, I in fact saw a lady in my clinic on Tuesday who's been referred to a asymptomatic aortic stenosis trial. But when you actually talk to her, her symptoms are very clear. Every time I do something, I'm getting the symptoms. And then I took her off. Well, she's not eligible for the trial because she's not asymptomatic anymore. And that got me thinking, would that have happened for a male patient, for example? So,
you know, just to follow up on what Vijay said, and maybe, Julia, you can also weigh in. I think that a patient says he is asymptomatic does not mean he is or she is asymptomatic. And I think an interesting finding of the recent trials was that up to 40% actually do have symptoms when an exercise stress test is systematically done. Although in clinical reality we are not doing this. It's done perhaps in 10% of patients.
Yeah, that's a very good point, because even the METs from the exercise test are actually prognostic, you know, or give you an indication that this patient does not have a great exercise tolerance. So the METs, then symptoms during the exercise test, in general, like have a low threshold to provoke the patient for symptoms.
yeah, I think we can keep on discussing. There's so many elements to discuss as well regarding the procedure and the anatomy, but I think for the sake of time, we will move on to the next presentation. Thank you so much. It's now my pleasure to welcome Dr. Gonska from Bad Neueheim Germany to discuss identifying predictors of valve longevity. So we're going to move from sex differences to discussing the valve longevity. Thank you, Birgid.
Yeah, it's a pleasure to be here, dear colleagues, dear panel, and it is trying to identify predictors that are responsible for how long our TAVR valves are going to last. These are my declarations of interest. So why is that an important topic? I mean, it wasn't 10 years ago we were treating octogenarians that received one valve and that was it. But life expectancy worldwide is going to rise in the next decades. And with that, we're also expanding our indication to younger patient groups, low-risk patients group who have a longer life expectancy ahead of them. These are data from the US, where you can see that there are almost 50% of patients below 65 years of age are being treated with TAVR. And now we have the new ESC guidelines, which are probably going to move the average age for TAVR treatment in Europe too, with a threshold of 70 years. So now life expectancy is going to exceed valve durability. So we have to focus on how to predict valve durability and which factors are important for that. So as Professor Windecker already showed, the VARC-3 criteria from 2021 are the newest definition of these endpoints. One is the valve deterioration or bioprosthetic valve dysfunction. That's basically the way the valve is degenerating. And then we have the clinical endpoint, bioprosthetic valve failure, which is valve-related intervention or death. We distinguish between structural valve deterioration that concerns the valve degenerating in itself to non-structural valve deterioration that is PVL or PPM, then thrombosis or endocarditis. And as Professor Windecker already pointed out, it's an echo-guided description that we're doing with mainly gradients and valvular AR. What do we know about valve durability and moderate SVD or bioprosthetic valve failure? Those are just a collection of data that we have from registries and trials, and we see that the rate is somewhere up to maybe 10% of bioprosthetic valve failure. So it's going to be an issue for our patients at some point. Is that different to surgical valves? Probably not. The NOTION trial showed 10-year data with a higher rate of SVD in the SAVR patients, however, not a higher rate in bioprosthetic valve failure. There's only 25% of patients still alive after 10 years. Then there's a pooled analysis from the CoreValve US high-risk pivotal and TAVI trials, and also there we see a higher rate of SVD in the surgical valves. What factors do contribute to valve degeneration? And it's one's clinical factors, it's age, sex, there are conflicting data on whether it's good to be a woman or not, and then classical risk factors for arteriosclerosis. Then we have the anatomical factors with the distribution of calcification and bicuspid valves and small annuli, and also that relating to PPM and underexpansion, but also probably valve design and commercial alignment may be important for valve longevity. Because these factors can relate or can lead to mechanical stress of the prosthetic valve and therefore enhance thrombus formation, endothelialization, and inflammation leading to fibrosis and calcification. So I just want to touch briefly on two different aspects, and one is age. It's not good to be young and have aortic stenosis. We already know that from the surgical data, that patients who are treated with a bioprosthetic valve at a younger age have faster rates of bioprosthetic valve failure. There are now data on TAVI as well, but that younger age is a predictor for SVD. Why is that the case? That's not really clear yet, but it's possibly an active immune-mediated process that leads to calcification, and younger patients have a more active immune system, so that might affect SVD development. Then patient-proteson mismatch, small annuli, and device design. What do we know about that? PPN has been associated in surgical valve with SVD and has been linked to, there are trends, not statistically significant so far, to SVD after TAVR. We know that PPN, as Grapsa already showed, is something that's relevant for the outcome of our patients. When it comes to small annuli and valve design, we know the data from the SMART trial had been touched already beforehand. That was a comparison of the self-expandable supraannular design of the Evolut valve with the intraannular balloon expandable valve Edwards, and we see that bioprosthetic valve dysfunction is significantly higher with the balloon expandable valve. Do we have more long-term data on that? A little bit. There are data from the CHOICE trial that was a randomized comparison of those two devices, however, the older generations. And we see that structural valve deterioration was significantly higher also with the balloon expandable valve. However, in 5 years, this did not lead to a significant increase in bioprosthetic valve failure. We'll see how that's going along as the years progress. There's a non-randomized study with over 2,000 patients. They could show that the balloon expandable valve did have a higher rate of SVD, and that also led to a higher rate of bioprosthetic valve dysfunction. So I would like to conclude that evidence is here still scarce. We have limited long-term data. Those are with old generation devices and with only few patients still alive after a longer period of time. We have reassuring durability from the data we have seen so far. Determinants of valve deterioration are multifactorial, patient characteristics, also procedural technique, and probably device design. And then it's really important that we follow up on that with consistent descriptions of how to measure that. And there's something I just want to touch briefly. This is all echo-guided descriptions, or how you describe how the valve deterioration is going on. We do not really know if these echo gradients are the same as maybe if we do an invasive measurement. So just something to think about. Then I thank you for your attention.
Thank you very much for this crisp summary on an important topic, valve longevity, and also highlighting already during the time of the first procedure that we do our best effort to attain the largest effective orifice area that is possible, which really is important in younger patients in case we consider re-interventions. I want to touch on two topics. One is we speak always in general terms, transcatheter heart valves versus surgical valves, but we do know from the surgical literature there have been many valves that have a very well-established longevity record. Conversely, there have been valves that actually have been withdrawn from the market due to very premature structural valve deterioration. Now, my question is, how do we reliably assess for newcomer transcatheter heart valves and rigorous assessment of that very aspect where maybe the implantation goes well, but we don't have long-term data until 10 years from now?
Well, really difficult to answer, I think, because like you're referring to trifecta. Trifecta had perfect first early results, and then it degenerated really quickly. I don't think we have a way of knowing that. If we have perfect hemodynamics in the beginning, we can only hope that that proceeds the way along. But yeah, long-term data, is that what we need? There's no way, I think, to answer that question beforehand.
No, but
do you think so?
I
Maybe.
think I would just make the plea first. It's very important in practice that we also do a regular echocardiographic follow-up of all patients. Actually, the guidelines recommend us to do this on an annual basis. And I also would make the plea that we have a societal responsibility to collect maybe on nationwide registries or otherwise reliable data in the long run. So it's really, I think, a societal effort. The second question I wanted to ask you relates to the importance of antithrombotic therapy in terms of the aspect of longevity. Do you want to comment what is your approach in your practice?
Well, we still follow the guidelines. With means just single antiplatelet therapy in those patients, because, I mean, when patients do have thrombosis of the valve, we do know that that leads to early degeneration. If not caught early, then doesn't resolve anymore. However, all the studies we've seen on that with oral anticoagulation versus double platelet therapy, double antiplatelet therapy or something else, always resulted in poor prognosis for the patients who have been treated aggressively with anticoagulation because of bleeding, because it's such a low number of patients experiencing real valve thrombosis.
Yes, and that's certainly an area which requires further research. And maybe a last question. So the age has been lowered to 70. And maybe you can comment from your practice in Germany, is that already reality? Or how does it impact your clinical practice?
Well, I'm glad it has been lowered to 70, because now we have an argument against the insurance companies, because that were in the position, like the region of Germany I'm in now, that was always the issue, the age. And it wasn't reimbursed. So now we can say where it can be reimbursed. And I think in other parts of Germany where that isn't that much of an issue, which is really interesting because it's the same insurances, but it is, 70 is widely accepted already.
And I hope the insurers know that it is a treatment that at the end is more cost effective. Well, thank you so much for this excellent presentation. And now it's a pleasure to invite Stefan James from Uppsala, Sweden, and he will inform us on how to generate evidence to support guidelines. Stefan.
Thank you, Stefan, Vijay, and co-speakers in the audience. I was asked to reflect a little bit on the guidelines and the importance of generating evidence to inform guidelines. These are my perceived or real COIs. So as you have shown already, the new guidelines that were presented yesterday, which I was a co-author of, lowered the age limit to 70 years in tricuspid AV stenosis, irrespective of surgical risk. So I thought that's a big change, I think. And surgical valve for patients below the age of 70. And this is based, of course, on a heart team evaluation. I think many have asked themselves, is there really randomized trials that can point at that 70-year cut point, because this is a class 1A recommendation. And in fact, there are no, as you know, trials that have really looked at the age cut point of 70, yes or no. But what the guideline committee did, they were looking at a number of randomized large trials with a reasonable duration of follow-up, looking at, for example, Dedicate 1 year, low risk 5 years, and Notion 10 years, and more trials than that, and showing that TAVI, with the mean ages of around 70, at least a large proportion of patients at the age of 70 or more, there is evidence that TAVI may be at least not inferior, in some instances superior to surgical valve replacement. Of note also here that there was a reasonable proportion of female patients enrolled in these trials. So the guideline committee thought it was reasonable to lower the age cut point to 70 years based on the data that have shown good results in those age groups. So it's more of an indirect evidence than direct evidence of that particular cut point. And I would say that I think it's needed to get more trials addressing that issue. The guideline documents specifically refer to the Dedicate trial. And of course, the reason for the superiority of TAVI versus TAVR in the Dedicate trial can be multifactorial. I think it's important and interesting to look at first, there was no interaction for age or sex in the overall analysis, but it's important to look at the valve sizes, selection of valves, and potentially it could be an explanation for the better durability and long-term effect of TAVI versus TAVI, because the TAVI group was able to implant larger valves as compared to the surgical valves. Here, I think Stefan's question is also important to say, my surgical colleagues in the committee say that so the surgical valves was a whole range of different valves, and including some really poor ones. But I think a message here that the guideline committee also discussed is it may be important to try to implant as large valves as possible in these patients in order to get these good results. With respect to age, the guideline document doesn't give any specific recommendation, but they do say that women, as compared to men, have higher in-hospital and long-term mortality and morbidity after TAVR, possibly explained by smaller aortic annulus predisposing to PPM. So the guideline document actually expresses this, that in TAVR, the small aortic annulus and the small valve selection may be an explanation. Further, they say that several large observational studies suggest that women, as compared to men, have lower long-term mortality after TAVI despite higher incidence of bleeding events. And there may be many different reasons for that related to the left ventricle, but also valve selection. Furthermore, they say in one comment that in one randomized trial, namely the RHEA trial, that included only women, TAVI as compared to TAVR was superior in reducing the primary endpoint as composed of death, stroke, and rehospitalization 1 year. And that is also maybe explained by selecting larger biological valve sizes. So looking at the RHEA trial, you've seen this before in this session, but TAVI for the duration of 12 months was associated with a lower primary endpoint. And looking at the valve size distribution, I think the same pattern occurs as my comment on the DEDICATE trial. There was considerably larger valves. This relates to SAPIEN valves as compared to the surgical group, which may be one important explanation for the favorable results long-term for TAVI in this trial. The guideline document does not give specific recommendations on selection of valve type. But I have to refer to the SMART trial again, despite the fact that the previous speaker did that, because this is a trial that's very relevant for the discussion with a large proportion of women with small aortic areas, and showing the lower risk of biprothetic valve dysfunction for 12 months in the supraannular valves. And again, I think we see the same pattern with respect to the sizes. Balloon expandable valves are possible to get larger sizes, which may result in a better long-term effect and lower risk of PPM. And in response to your question, Stefan, I think it's important that we generate more evidence in this area. And as you know, we are also now successfully launching the EuroHeart registry. And we have already, in the PCI setting, we have 14 countries that are contributing with all their national data, every single patient. So we are able to put together more than 200,000 patients annually on PCI. And from next year, we're launching TAVI as the next big registry. And we have already discussions and contracts, agreements with a large number of countries to do that: Sweden, Denmark, United Kingdom, France. I think we're able to do Spain and Italy as well. We have very good discussions with Germany. If we're successful, so we will be able to, I think, for sure, almost, that in 2 years we can really here at this meeting show data on individual patient level from hundreds of thousands almost of patients from most of Europe. And then we will be able to, in an observational format, to see patterns along these lines. What does it matter to select larger valves versus smaller, different type manufacturers in relation to sex, gender? That's the aim of EuroHeart. And so that's a sort of a teaser for the coming years. So I think, and I again want to reiterate that evidence generation, I think, is critical. We need to understand what we're doing from randomized trials, preferably, but also from registries. And TAVI is given an increasing level of support now in the guidelines, so it's up to us also to show in registries the effect of that generation. How does that affect the outcome of patients? And we need to get more evidence in these registries and in trials, more of individualizing treatments in relation to sex, risk, age, expected survival. LV function, I think, is increasingly important to understand, and annular dimensions. So I'm very optimistic on the future, what we will be able to do in understanding these issues. Thank you.
Thank you so much, Stefan, and I think I should disclose that you are responsible on the level of the ESC Clinical Practice Guideline Committee for commissioning the major guidelines such as the VHD guidelines, and that this is a fantastic activity of the ESC, so thank you for all the efforts there. But at the same time, we also need to acknowledge your pioneering work within Sweetheart, where the evidence generation as it relates to devices in an observational format is really exemplary. I think I would acknowledge that probably there is no device that is so rich in terms of evidence as what has been generated by TAVR, and I think we need also to acknowledge the contribution of industry contributing to leveraging this evidence. And maybe I can just ask one question as it relates to the Euro Heart Registry, which I agree will be a great opportunity to investigate the long-term durability. But what do you think would be the appropriate, let's say, endpoint or way of follow-up? Should we rather regress to what has been done in the surgical era, where we just look at levels of reintervention and mortality? Or do you think that echocardiographic follow-up needs to be an essential part of that long-term observation?
Yeah, I think that's a great question, a very important one. And ideally, I would like to see echo data, long-term follow-up. The lowest hanging fruit is the clinical endpoints that we can get automatically from ICD codes. So that is rehospitalization for heart failure, reinterventions, survival. But we'd also have discussions in the team to link echo databases. As echo databases get more available, more of them are digitalized. It's going to be, I think, possible in the future also by using AI to get that data. But we're not there yet. But that's something we need to work for in the coming, not 2 years, but maybe 5 to 6 years.
Thank you so much, Stefan, once again. So I shall bring, let's clap. I shall summarize our session and bring some take-home messages. What we have learned from 3 of our incredible presentations this afternoon is that there are important sex differences, and it's now time that we stop mentioning it, but really taking proactive measures to address them in terms of raising awareness, diagnosing, and treating them. In terms of valve longevity, it's really fantastic that the guidelines has given a 1A recommendation for 70 years of age and over patients, meaning if you put a TAVI at the age of 70, and I've got patients who are 98 years of age, so we really need them longevity to be 28 years and beyond. Who knows how long people are going to be living in the era of population aging. So, and as mentioned already, we do need to generate more evidence accordingly. And you are correct in that there are no sex-specific recommendations. Having worked on the guidelines, I get asked that as well, Vijay, why is there no specific recommendation? In order to give recommendations, recommendations are based on randomized clinical trials or patient-level meta-analysis. We must generate evidence, meaning we should continue to generate evidence basically, primarily in female patients for us to have specific recommendation. I'm sure that will come in the future. And also we discussed the type of valve that we implant into these patients. And one thing I want to also highlight, although there's no specific recommendation, I was very pleased to see a longer paragraph in the guidelines explaining the sex differences, describing it so people can read it and put that into their daily practice. And as Stefan, Professor Windecker alluded, we do need registries. And from my perspective, the registries provide so much information. We could be sitting in our cath labs and in our offices thinking we're doing a fantastic job, but if we look at the real world, things are not as they should be. And they help us to identify the problems and feed that back and address them. So there is still plenty of work to do. And I'd like to take the opportunity to thank my co-chair, Professor Windecker, and also for all the presenters, Professor James, Julia and Birgid, for your fantastic presentation. And thank you all also for attending this meeting. Thank you very much.